Well, good morning, everybody. I am Dr. Laura Lacher, and welcome to today's Medical Grand Rounds. As usual, we'll go ahead and get started with some reminders and logistics, and then introductions for today. Wanted to let everybody know that our talk, Long COVID and Chronic Fatigue Syndromes, given by Dr. Becca Kennedy, has been rescheduled to April 22nd this spring in order to be able to have her present live to our audience. So please get that one back on your calendars. We will have no grand rounds next week. This is a schedule change due to ongoing strike at Providence St. Vincent, and we appreciate your flexibility on that. We do plan to have grand rounds the following week, February 11th, to hear Dr. Schaefer's Thieves Market, a fun, engaging, and interactive case-based presentation. Hope to see you back live in person, but please stay tuned for updates. And just a few logistics reminders. We are here on the Teams Live platform. Grand Rounds is a shared endeavor between Providence St. Vincent and Providence Portland Medical Center. We often have Grand Rounds live in person on Tuesday mornings at 8 a.m. at St. Vincent, and sometimes at noon on Tuesdays at Providence Portland. Your weekly Grand Rounds invite will always let you know location options. And you can earn CME credit by being with us here on Teams Live, by being in person, or watching a recording of the event. And again, that recording is available at the same link as the Grand Rounds invite. I'll be monitoring the Q&A throughout the presentation today, so please go ahead and post any comments or any questions you have, and I will mostly hold those until the end to ask as time permits. And now for introductions. I'm delighted to have with us Dr. Elise Anderson, a practicing neurologist with Providence specializing in movement disorders. She earned her medical degree from University of Southern California and did residency in neurology at David Geffen School of Medicine at UCLA, followed by fellowship in movement disorders at OHSU. Dr. Anderson treats patients with a wide range of neurologic conditions with particular focus on Parkinson's disease, essential tremor, and cervical dystonia. She provides botulinum toxin injections and deep brain stimulation management as well. She enjoys spending time with her family, greyhounds, running, tennis, cooking, and eating. Dr. Anderson is well known for her quality of teaching, and we are so delighted to have her here to share her expertise. Thank you.
Great. Well, thank you very much for having me this morning and for joining the talk today. My name is Elise Anderson, and I practice neurology over at our East Side location at PPMC. And as a movement disorder specialist, I take care of patients with tremor, and that is our topic for today. So, let's see. Our roadmap for our discussion today is the clinical evaluation and diagnosis and management of tremor. So that's a massive topic. My goal today is to present a very clinically relevant presentation to give you a blueprint in terms of how we evaluate tremor in clinic, review the presentation of the most common tremors we see, and then review diagnostic modalities, so testing for various causes of tremor, and then medical and surgical treatments. Inevitably, a lot of what I'll talk about is going to be our kind of bread and butter diagnosis in movement disorders, which is Parkinson's disease. And that's really what a lot of people are worried about when they come to see us for tremor. Excuse me. But of course, I'd like to talk about some other common causes of tremor that we see in clinic as well. So by way of definitions, tremor is a rhythmic oscillation of a body part around one or more joints. This is an involuntary movement, and tremor really is generated by a central source, meaning tremor comes from the brain. So sometimes patients will be concerned that maybe a pinched nerve or some other peripheral process, maybe peripheral neuropathy, is the cause of their tremor, but really This is a phenomenon that comes from something going wrong centrally with those complex networks and pathways that modulate movement going out of whack. And there can be a variety of causes of that we'll chat about today. However, interestingly, even though we think of tremor as being a central process, there are some peripheral components that that we can see in clinic and also capture in therapy. So we know that, for example, loading a limb, for example, with weighted utensils in essential tremor can diminish the amplitude of an essential tremor, but doesn't seem to impact a enhanced physiologic tremor because the physiologic tremor has a different cause. We also have seen a lot of interest recently in peripheral therapies for Parkinson's. So a lot of you may have heard of the Parkinson's glove, which is a glove that is worn that delivers vibration stimuli to the hand that provides a feedback to the brain that seems to modulate the tremor in Parkinson's, and that's a therapy that's undergoing study up at OHSU right now. There are also wristband devices for essential tremor that have been around for a while that also seem to do some feedback modulation of those central tremor generators. So there is an interesting peripheral component to treating tremor, but really we think about this as coming from the brain. So to talk a little bit about what we do in clinic when we're evaluating tremor, just like with everything else, we start with the patient history. And in terms of tremor, the age of onset and the acuity of the tremor are really the first points of assessment. So in terms of age of onset, in roughly younger than 50 and older than 50 are kind of the starting points in terms of how we start to categorize things. So most tremors are that we see in clinic are subacute tremors. If somebody has an acute onset tremor, often they're going to be evaluated in the emergency room. So a subacute tremor in a patient younger than 50 typically is going to be related to medications. It may be an essential tremor, or it might be an enhanced physiologic tremor. And so just a few bullet points on what an enhanced physiologic tremor is. This is a physiologic tremor, which is the tremor that all of us have that emerges with stress or anxiety. And so this is a very low amplitude, symmetric, high frequency shaky tremor. And it is a tremor that comes out with triggers that increase sympathetic tone. It is generally present at rest and with posture and action. And so it's generally equally present in all of those different positions. And it is due to a mix of normal physiologic loops and peripheral muscle spindle firing. And then enhanced physiologic tremor is a tremor that is simply more prominent in some patients. So some patients simply have a lower threshold for the emergence of this tremor, and it's more or less there all the time. Or sometimes the enhanced physiologic tremor is a response to physical, emotional stress, metabolic derangements, certain medications, but generally it's regarded as a benign tremor. And we see that fairly often in patients, especially in younger patients. In older patients, and for the purposes of this classification, we'll say above 50, that's when we start seeing more and more diagnoses of Parkinson's disease. So I'll be increasingly worried about that in older patients. And then, of course, for acute onset tremors, typically that is going to be either related to a new medication or a new brain lesion. And so stroke can produce a new asymmetric acute tremor, and also an MS lesion can produce a new acute tremor. And then also a functional tremor. So the older term for this would be a psychogenic tremor. A functional tremor represents movement disorder that is seen in patients who have a normally function CNS neurological systems, but their brain is sending signals that produce abnormal movements. And we'll talk about that a little bit more today as well. And then, of course, when we're taking the history and reviewing the patient's chart, medical conditions and the associated treatments for those conditions are often clues to the source of a tremor, particularly patients with hyper or hypothyroidism, patients who are on psychiatric medications. And so I think in terms of the medication-induced tremors that we see in clinic, patients who've been on antipsychotics for a long time can develop Parkinsonism. And that's a relatively common referral question to help sort out whether a patient is developing Parkinson's disease or is developing symptoms of Parkinson's due to dopamine blockade associated with antipsychotics. And probably the most common culprit we see here is aripiprazole or Abilify. Since it is a very effective treatment for refractory depression, a lot of patients are taking it. And over time, a certain percentage of those patients will develop Parkinsonism. And it's tricky to sort out because with antipsychotics, stopping the medication doesn't result in immediate resolution of those symptoms. You know, if a patient is taking lithium or Depakote and you decrease or taper them off that medication, you will see the tremor resolve, whereas it can persist 6 to 12 months after stopping an antipsychotic. And so we have other strategies to sort that out. We see less Parkinsonism these days with antiemetics, but they also can block dopamine. And then another scenario where we'll often see medication-induced tremor in patients is related to therapy with SSRIs, especially in combination with pain medications. So this combination of medications increases serotonergic tone, and this can produce kind of a tremulous, jerky myoclonus that we can see in patients as a result of that increase in serotonin. And in those cases, often these patients need to be on those medications, and it's tricky to try to sort out which or how many of these meds is causing the problem. But that is another medication scenario that's relatively common. So the next step in evaluating patients in clinic when we're sorting out their tremor is the location of the tremor. So upper extremity or arm tremor, when a patient usually will see, patients are referred primarily for arm tremors more than leg, but we'll see that a little bit as well. So we tend to think in terms of whether somebody has a unilateral or asymmetric tremor, which is generally going to point us towards Parkinson's, or some sort of a lesion, again, MS or stroke, or a more symmetric tremor, which tends to point us more towards essential tremor, enhanced physiologic tremor, or a medication-induced tremor. Patients are referred for head tremors relatively often, and really the question there is whether it's really primarily an isolated head tremor or head much more than limb tremor, which is going to suggest cervical dystonia, and we'll talk more about that as well. If a patient has both head and limb tremor, that's usually more of an essential tremor picture. And then finally, now and then people will be referred for leg tremor. Parkinson's can present with an isolated asymmetric leg tremor. And we also can see a rare phenomenon called orthostatic tremor. And that causes leg tremor in patients only when they're standing. And it's a very high frequency, low amplitude tremor, so much so that often you can't even see it, but it can cause a lot of imbalance and instability and falls. And the ideal way to diagnose this is actually with EMG to capture that high frequency tremor. But often it is a clinical diagnosis based on a patient's description of this tremor sensation that occurs only when they're standing, that resolves when they start walking or when they're seated. Okay, and then other clinical findings are the features of the tremor. So you'll hear us talk a lot about a rest versus an action tremor. And so we'll do a couple of maneuvers in clinic to try to better characterize when the tremor is most prominent. So a rest tremor refers to a tremor that occurs when a patient is not using their arm. And so that'll emerge when patients are sitting chatting with you in the exam room. And typically a rest tremor will resolve when we start using the limb to do various postures or movements. So a rest tremor is typically a Parkinson's tremor, but we can see it in essential tremor, especially if a patient has a very severe essential tremor, or in the enhanced physiologic tremor. In contrast, a postural tremor, when we have patients raise their arms and reach them out in front, that's really when we'll start seeing more movement with an essential tremor, or again, the physiologic tremor. And then a kinetic or action tremor occurs with movement. And so this is classically what we'll see in essential tremor. So this is the tremor that patients find is really bothersome when they are reaching for objects, holding a glass of water, trying to write. And so we'll see that in the essential tremor, but also with tremors that are caused by cerebellar lesions and dystonia. And we'll talk a little bit more about dystonic tremors, but those are often more of a action tremor when patients are reaching for objects and trying to use their hands. And then an intention tremor is a kinetic tremor that's most prominent as you're approaching the target. And then finally, we talked a little about the orthostatic tremor as well. So in terms of clinical pearls, probably when I'm examining patients and we're trying to sort out if a tremor is due to Parkinson's versus essential tremor, probably the two most helpful things that I find that we can do if a patient has components of both rest and an action tremor are to have the patient walk and have them take a sip of water. So a Parkinson's tremor sometimes will be present primarily only on gait exams. So even though a patient's noticed a tremor in their daily life, we might not see it in clinic until they get up and walk. And so a tremor that's evident really just with gait exam really points you much more towards Parkinson's disease. Often an essential tremor, patients can be very shaky on exam in the exam room, but when I have them get up to walk, that essential tremor will largely evaporate. By contrast, an essential tremor tends to get very prominent when I have patients take a sip of water. And so that glass of water can get very, very shaky, especially as it approaches their lips. Whereas in contrast, often even a very shaky Parkinson's tremor will diminish substantially when a patient grabs a glass of water to take a sip. And so those are things you can do in clinic to help tease some of these things out. And then just very briefly, there are different amplitudes and frequencies associated with these tremors. And probably the things that I find the most helpful in terms of what we're looking for clinically is we see a much more irregular tremor and dystonic tremors. So these can be much kind of jerkier than the more rhythmic tremors that we'll see in Parkinson's essential tremors and medication-induced tremors. And then sometimes the frequency and amplitude of a tremor can be very variable in a functional tremor. So in particular, if we think somebody has a functional movement disorder or a functional tremor, using techniques like entrainment, which refers to having a patient extend their arms and having them try to match my finger taps. If I do finger taps at a different frequency than the tremor I'm seeing, and the patient's able to match that, often if this is a functional tremor, meaning again, their neurological systems are intact and functioning normally, the tremor will start to match those finger taps. Whereas a tremor due to essential tremor or Parkinson's will maintain the tremor frequency due to aberrant neuronal firing that's causing the tremor. And then, of course, distractible or suggestible tremors are also seen in functional movement disorders. So tremors that are really only present when you're talking about it, or sometimes suggestible, meaning some exam maneuvers seem to trigger a tremor. And so sometimes we'll see patients get really shaky just when we're checking their reflexes or doing a maneuver like checking vibration with a tuning fork. Those are really more suggestive of a functional tremor. So we're going to do a couple of videos now looking at different types of more commonly seen tremors. This is not a particularly commonly seen tremor in clinic because this is a gentleman who has an MS lesion, but I like to show this video because it really shows typical features of a cerebellar tremor. So very coarse, high amplitude tremor that's seen. It's essentially completely unilateral on the side of the lesion, and we see kind of this wing beating appearance, especially as his limb gets closer to the body, which is characteristic of cerebellar and also brainstem lesion-associated tremors. The next tremor that we'll talk about is essential tremor. So as I've mentioned, this is an action tremor that patients report affects their limbs, their voice, their head, and it really affects movement. And so writing, eating, and other fine motor tasks are implicated. There is a strong autosomal dominant genetic component, but we don't know what specific genes are involved. We do know that tremor, essential tremor, is caused by dysfunction of these networks of neurons connecting the cerebellum, the thalamus, and the cortex. Something goes off kilter in that network, but exactly why this happens in essential tremor patients is not clearly understood. And this is a disabling condition in some patients. For most patients, it's progressive and annoying. And in some, it can really interfere with their ADLs. So this is an example of the latter. This is a patient who has a very severe essential tremor. And so you'll see he has this really minimal rest tremor, but much more prominent postural tremor. And then once I ask him to do an action like this finger to nose test in clinic, we see a lot of shakiness as his fingers approach the target. And so this is a gentleman who I wouldn't even ask to take a sip from a glass of water in clinic because it would just end up everywhere. And so you see, as he's doing some finger taps here, the tremor intrudes and really affects his ability to use his hands. So the next class of tremors that I'll touch on is a dystonic tremor. So dystonia refers to involuntary movements or postures due to co-contraction of opposing muscle groups. This is really a heterogeneous group of disorders that are classified in 3 ways: by age of onset, affected body parts, and cause. Causes include primary, which really refer to genetic dystonias, idiopathic dystonias, meaning we don't know what causes them, or acquired dystonias due to strokes, for example, or we can see dystonia in neurodegenerative disorders and like Parkinson's disease. In terms of the identification of a dystonia, what we're really looking for is very stereotyped movements or postures that reflect a specific activation of muscle groups. Because really what dystonia is an abnormal signal from the brain telling opposing muscle groups to act against each other. And where we see this primarily in neurology clinic is in cervical dystonia, which is the most common primary dystonia, and produces a head tremor that we'll see an example of here in a moment. Blepharospasm is a dystonia. Another common one that we'll see is a primary writing tremor. And so this is a video of a patient who was referred for tremor that's really bothersome in writing. And you see there's kind of irregular, jerky quality to this tremor. He finds that it's easier to write by holding his pen in a fist, as you see here, which enables him to control the tremor a little better. When a patient's referred, reporting that they have a really bad tremor that affects writing, generally the first thought's going to be essential tremor, because essential tremor causes a lot of difficulty with writing for patients. But in this case, we'll see that this patient has essentially no tremor with posture or finger to nose testing. So it's really a task-specific movement disorder that we're seeing here. And this is the form of dystonia that causes tremor for patients who do a repetitive task. And so writing is one of them. If you've heard of musician's dystonia, patients who are professional musicians who do the same movements over and over with their hands or their lips in performing can develop involuntary activation of the pathways that execute these movements, and an intrusive tremor can result. And I've also seen this in other professions. So I recently saw an ER doctor who had a change in his work responsibilities and was doing a ton more charting than in the past. And he developed an involuntary movement of his wrist that essentially mimicked using a mouse. That was really intrusive and affected his ability to continue to do that aspect of his work. So dystonias can be challenging to treat because of the strong signal from the brain. If we can, our first choice is to treat with Botox, and that is what that's the approach we use with cervical dystonia. So again, this is the most common focal dystonia, tends to produce involuntary activation of neck muscles, producing muscle spasm and a head turn and often a tremor. This tremor comes both from involuntary muscle activation, but also from the brain's effort to correct this abnormal head position. And so that correction results in a multi-directional, irregular, kind of a bobblehead tremor. Often patients with dystonia will have a sensory trick of disrupting that kind of abnormal outflow of signals with touching their chin or cheek, and that transiently kind of interrupts those signals and settles the abnormal movement and tremor. And really the take-home lesson for this is if you see a patient who has much more head tremor than limb tremor, then I would encourage you to think about cervical dystonia, which has a different treatment than essential tremor. And here we see a patient who has a fairly characteristic jerky, irregular head tremor, and you see that she has a bit of a lateral shift, a little bit of a primary head turn to the right, and she has a moderate amount of limb tremor. She has probably a little bit more than is typical, but this is a patient who has a very kind of characteristic appearing cervical dystonia. Okay, and so our next stop is Parkinson's disease. So Parkinson's is the second most common neurodegenerative disorder. It's caused by a loss of dopamine production in the brain, and it produces 4 classic motor symptoms. The one that we tend to think of is the Parkinson's tremor, which is a asymmetric resting tremor. The other symptoms that we'll be looking for in clinic will be some of these other motor symptoms, rigidity, bradykinesia, and postural instability, which really refers to the gait changes in Parkinson's. But we also, in terms of managing Parkinson's, we end up talking quite a bit about non-motor symptoms as well. So these can be psychiatric and mood changes, bowel and bladder symptoms, sleep disruption, cognitive decline and dementia, autonomic dysregulation. So Parkinson's is really, it's a complex disorder, but when we are in the context of tremor, this is really what I think a lot of people are worried about, that we're trying to rule out when we see somebody in tremor clinic. So here is a fairly classic right-sided, so asymmetric rest tremor. We see kind of a pill rolling quality there. The leg is also shaking, and these are a few of the maneuvers that we'll do to kind of look for other findings of Parkinson's disease in terms of slowness and stiffness. One thing I will point out with this patient's video is you'll see he has this pill rolling rest tremor that resolves transiently when he holds his arms up, but then it reemerges, and that's kind of a typical finding in a Parkinsonian tremor. You'll also see that he has the decreased blink rate, the slightly open mouth, the kind of paucity of spontaneous movement that's really the hallmark of Parkinson's, which is bradykinesia or slowness. So in terms of our workup in clinic to try to sort out the cause of a patient's tremor, we actually don't do a great deal of testing. So there are a few labs that we'll obtain depending on certain considerations. If we're worried about thyroid or Wilson's disease, often a key part of our workup is a levodopa challenge. So if a patient appears to have Parkinson's disease, Parkinson's is really regarded as a clinical diagnosis, meaning if they look like they have Parkinson's and their symptoms respond to levodopa, that confirms the diagnosis. Now, as we know, there can be a lot of confounding considerations that can make it harder to diagnose Parkinson's, but a classic Parkinson's diagnosis remains Parkinson's symptoms that respond to levodopa. For other cases, we will obtain imaging for an acute onset tremor, again, to rule out a stroke or other lesion. And we do have some other testing available to us for getting more information about a potential Parkinson's diagnosis. And so a few slides about that. So while traditionally Parkinson's is diagnosed with a levodopa challenge, sometimes we don't get clear results from that, or patients would like to have more confirmatory testing. And so we have a couple of options that way. The Sign 1 skin biopsy is a test we're doing in a neurology clinic increasingly often, and this is a skin biopsy that identifies phosphorylated alpha-synuclein in cutaneous nerve fibers. So phosphorylated alpha-synuclein is the abnormal protein that accumulates in Lewy bodies in the brains in Parkinson's patients. It turns out this can also be identified in the periphery. And so we do a skin biopsy for this stuff in 3 sites, on the shoulder, leg, and ankle. The abnormal protein is found in Parkinson's and a few other disorders that are associated with synucleinopathies. And so Lewy body dementia, MSA, and primary autonomic failure will also produce abnormal biopsies. And this is something that we can do in clinic, which is appealing for a lot of patients. Another test that we are not currently offering in clinic, but it's interesting to know about, is a spinal fluid test for alpha-synuclein. And this is really being regarded as the first reliable biomarker for Parkinson's disease. So I think this is increasingly going to be used in clinical trials as a way of making a biologic diagnosis of Parkinson's, which is really a shift from our historic clinical diagnostic approach to Parkinson's disease. So this isn't something that we're doing here, but I think we'll be hearing more about this going forward in terms of diagnostics in Parkinson's. The other test that we have been doing quite a bit of for a number of years now in movement disorder clinic to identify Parkinson's disease is the DAT scan. And so this is a SPECT scan that is available at St. Vincent's and at Prov Portland. And this is a radio tracer binding study in which the binding is to the dopamine transporters in the striatum. So if you have Parkinson's disease, you have decreased production of dopamine, and as a result, you'll have a decreased number of dopamine transporters in the brain. And so we'll see an asymmetric loss of dopamine transporters in Parkinson's disease, as well as a couple of other disorders, again, with decreased dopamine production, such as Lewy body dementia or MSA. But if you have Parkinsonism due to medications such as dopamine blocking antipsychotics or vascular Parkinson's, or if you don't have Parkinson's at all but have an atypical presentation of essential tremor, you will have a normal DAT scan. And so it's a useful test to, again, sort out, in particular, whether somebody has Parkinsonism due to a non-Parkinson's disease cause. So this is what it looks like. So picture A here is a normal subject with a normal amount of a normal number of dopamine transporters, and these light up here in the basal ganglia in a kind of symmetric comma-shaped picture. A patient who has Parkinson's, or in this case, somebody who has a genetic abnormality and will go on to develop motor symptoms of Parkinson's, will have a decreased amount of binding, and it'll typically be asymmetric. So you see kind of an attenuation there, particularly in the putamen where the decrease in binding is seen earliest. So this is available at here at Providence. We do quite a bit of this. It's also not a perfect study, so sometimes we'll see that the patient's pictures might look normal, but the numeric or quantitative report is abnormal, or vice versa. And so there's, often not often, but periodically we will find a equivocal result. Parkinson's. Levodopa is converted into dopamine in the brain. Carbidopa keeps that from happening until the levodopa is able to cross the blood-brain barrier. We generally start carbidopa, levodopa, or Sinemet in patients who are over 60. Patients who are under 60 often will start with an alternative medication because we're hoping to avoid dyskinesia, which is that involuntary wiggly movement that is a side effect of long-term levodopa exposure. In a typical patient over 60 who you're worried about Parkinson's disease, it's very reasonable to start carbidopa, levodopa when you refer them to see us in neuroclinic. We can always stop it if it's not helpful or if patients have side effects, but that is really helpful information for us to have when we see them initially in clinic. Carbidopa, levodopa is available in a lot of different formulations at this point. There are long-acting formulations, inhaled formulations. There's a gel-based intestinal delivery. There's a new subcutaneous delivery that uses kind of the same strategies as an insulin pump. And so there are a lot of different ways of getting carbidopa-levodopa into patients and I think really this reflects that even though this is a drug that's been around a long time, this remains our best medication for treating Parkinson's. That being said, I also want to note that treating a Parkinson's patient really is a comprehensive effort, meaning we rely a lot on medications, and we have newer and better medications now than ever before. But ultimately, it really is a team effort. And so we work a great deal with primary care and other providers within Providence. And we work very closely with our rehab teams, so PT, speech therapy, occupational therapy, and we have some fantastic therapists within Providence. And you know, say what you will about Epic. One nice thing about Epic is that it really makes coordination of care amongst all of these people within Providence much easier, and it really benefits patients to be able to reach out to their other care providers. And so I'm really grateful for that. We have a interdisciplinary Parkinson's clinic that we offer every other month, in which patients come to see us, as well as PT, OT, and speech therapists. And so patients see all of us together, and then we get together and meet to talk about the patient and develop a comprehensive plan of care for them. And so an interdisciplinary approach is really a great strategy to take care of Parkinson's patients. And we do our best to do that for our patients. So pivoting back to a few more notes on tremor medications. For essential tremor, we really have two good treatments for ET, propranolol and primidone. And depending on the side effect profile in the patient, we'll typically start with one of these. Second-line medications can include gabapentin and Topamax. Ultimately, if a patient has a severe essential tremor and these medications are not helpful, then we'll end up talking about surgical options. And in terms of dystonia, Botox really is our first-line treatment for cervical dystonia and some of these task-specific dystonias that I referred to, and also for the limb dystonia that we'll see, for example, in Parkinson's disease. Medication options include clonazepam and trihexyphenidyls, but it's a really strong signal from the brain that produces dystonic movements. And so typically the amount of the dosing of these medications that will actually impact the abnormal movement tends to be sedating. And so in some patients, we will also consider DBS. This is a deep brain stimulation is an FDA approved treatment for dystonia as well. So last few slides here talking about surgical options for treating tremor. And so really there are two main surgical options here. A newer technique that's available here locally at OHSU and through Providence at Swedish Hospital in Seattle is focused ultrasound. And so this is an MRI-guided ultrasound treatment that creates a little scar in the thalamus for tremor due to both essential tremor and Parkinson's disease. It is non-invasive, and so it's appealing to patients for that reason. But it can produce side effects in terms of ataxia, sometimes some oral paresthesias. It is only available to do on one side at a time, but surgeons are offering to do the other side in patients who would like to pursue that. So that's one option. The other option is deep brain stimulation, which is offered here at Providence. And this involves surgical implantation of leads deep in the brain to modulate those tremor pathways and reduce Parkinson's symptoms and essential tremor. So this is a picture of Seth Oliveira, who is our neurosurgeon who does our deep brain stimulation surgeries here at Providence and does a fantastic job. So we think about DBS for Parkinson's disease when patients who have done well with medication over the years, but they're starting to run into more side effects with medications or dyskinesia. And we have two options to target in the brain for Parkinson's disease, depending on their constellation of symptoms. And so a lot of our work in neurology clinic is in terms of deep brain stimulation is to identify patients who will benefit from surgical therapy. And to make sure if they're interested in pursuing that they have that as an option. But at the same time, making sure that we don't send patients to surgery who could potentially do worse. DBS can worsen balance and it can worsen cognitive symptoms and speech. So patient screening is really important. And that's a time-consuming process that we do in clinic. We have a fabulous coordinator, Teresa, who helps with this process. And it is more involved than focused ultrasound, but it also enables optimal tremor therapy because it is a programmable treatment that we can control in clinic for best results. So and so you can see in his case, he doesn't look too shabby, but he does not pass what I call the Costco test. If you saw him in Costco, you'd see that he's a little stooped, he's shuffly, he's got that characteristic tremor that emerges when he's walking. And so clearly this is a patient with Parkinson's. This is him a few minutes, an hour or so later after his initial programming. And you can see he's swinging his arms more freely. He's walking more normally. The tremor has responded nicely. And he would actually, I think, he would now pass the Costco test. He's largely, his motor symptoms are normalized with this initial pass at programming. And so he's a good example of somebody who is a good candidate and did well. Final slides here about DBS and focused ultrasound for essential tremor. These are both really potentially great therapies for patients who have a severe refractory tremor. Ultimately, the choice between them depends on whether you are comfortable with a more invasive treatment that enables you to have bilateral tremor control and programmable results, in which case you'd want to go with DBS, with a less invasive a patient who's interested in a less invasive therapy or might be more medically fragile, focused ultrasound might be a better option, but you get the results you get. So this is not something that you can modify the benefits after surgery. And so this is our patient that we saw from before, who, as you recall, had the really bad essential tremor. And this is him again later in the same clinic visit after his initial programming. And so for a patient who has just a really disabling tremor like his, surgical therapy really is our best chance at obtaining meaningful tremor control. And while his tremor isn't gone, as you can see now, he is a guy who could hold a glass and have improved function. So that was my last patient video. I do get now to show one of my favorite videos. So in movement disorder clinic, we love talking about tremors, but we also love talking about our dogs. And so this is a combo deal of my first greyhound, Schweik, who had this very cute little fluttery jaw tremor that he allowed me to take a video of. And that is it. So thank you so much. I think I finished almost on time. And I think now it's time for questions.
Fantastic. Thank you so much, Dr. Anderson, and for sharing your sweet doggy. We do have a bit of time for questions. First one up is, could you speak to the timing for a DAT scan if an empiric trial of carbidopa-levodopa has already been tried? And I suppose incorporating sort of, what the response was to the carbidopa-levodopa and how that might frame the decision for DAT scan.
Yeah, so that is often a good reason to consider a DAT scan. So sometimes a carbidopa-levodopa challenge is not successful because we simply weren't aggressive enough. So really getting up to 900 milligrams or 3 tabs 3 times a day is the target before we can say a patient hasn't responded to levodopa. But sometimes patients just can't do that because of side effects. Or they have Parkinson's symptoms. Maybe they don't have a prominent tremor, but they have stiffness and slowness and shuffling and symptoms that because of other comorbidities it's really more difficult to discern if they're having a robust response to levodopa. And so then that's really nice timing for more testing. So a DAT scan is a good choice. Or a skin biopsy is also reasonable. And some of that just comes down to if patients have a preference either way, or if they are on medications like bupropion or Buspar that can confound the DAT scan, then these days often we'll be leaning more towards the skin biopsy.
Great, thanks so much. Is there a role for stem cell transplant for Parkinson's disease?
Hopefully. So there, the studies looking at stem cells have been going on for a long time, and some of them have been really encouraging. But we still do not have an FDA-approved stem cell therapy for Parkinson's disease. And I think, in general, the problem has been that there's just been a lot of variability in how the patients do with the stem cells. So until we can really see more consistent outcomes, we're not there yet in terms of FDA approval.
Great, thanks. Hopeful for the future.
Yeah.
Returning just a moment to the levodopa challenge. Thank you for empowering us in primary care to feel like we can do this and start this as a therapeutic and diagnostic tool, perhaps on their way to neurology. Any logistics that we should be aware of in terms of timing, side effects, or expectations that we should really set with the patient to make this more successful?
Yeah, so if you are interested in empirically starting levodopa with a patient, what I would encourage you to do is to message me in Epic, and I will share with you my dot phrase, which is basically a couple of bullet points. I have patients start half a tab 3 times a day, and then advance to 1 tab 3 times a day. I caution them about fatigue and nausea. Often the nausea can be managed with having a small snack when you take the medication. And then having, again, the patient advance the medication cautiously over a week or two. And easiest thing to do is just message me and I'll share that with you.
Great, thanks so much, Dr. Anderson. It was really interesting to hear about the orthostatic tremor in the leg. Question is, how commonly is that seen, and any specific treatment modalities for that one?
It's not a particularly common diagnosis. It probably is missed quite a bit by all of us because it is hard to see, and because gait instability and imbalance are common in general. So we probably are missing it. It's hard to treat. So we basically use our medications that we use in essential tremor. So primidone, propranolol, gabapentin. And the results are usually some improvement, but it can be a stubborn and in some cases kind of disabling condition.
Yeah, thank you. I know you spoke to this a bit early in your presentation, talking about medications that might cause or worsen tremor, particularly when thinking of enhanced physiologic tremor and essential tremor. You mentioned SSRIs, particularly in combination with pain medications. Can you remind us any other medicines that we should be particularly aware of? Yeah, specific about meds.
You know, when I was doing my review for this, amiodarone was at the top of the list. I don't actually see a lot of referrals for an amiodarone-related tremor, but that might be because cardiology is on top of that, and they kind of have know what to expect. I think it's hard with SSRIs because it depends on the patient. So I think Effexor is probably considered the most tremorgenic SSRI in the literature. But I'll have patients who come and tell me that they had a tremor on fluoxetine and it went away when they stopped, or with other SSRIs. So sometimes it really is just driven by the patient history. And again, the combination of medications. So I think that combination of pain meds and a couple of SSRIs is when we really start to see kind of tremulous, shaky, myoclonic jerks in patients who just have polypharmacy going on.
Thank you. I'll take one last look here for final questions. Looks like we are approaching the top of the hour, and so thank you so much, Dr. Anderson. We'll look for your dot phrase on starting levodopa in EPIC. Thank you for your teaching.
Absolutely. Thank you so much. Have a great day.